Hello anatomy colleagues, this is Dr. Alsup, and we are coming to the end of our concepts for the regional portion of the musculoskeletal anatomy. So we are going to finish our conversations with the lower limb. And similar to what we did with the upper limb and the rest of the regions, we'll start with bones, then talk joints, and lastly finish with muscles. Now, you'll see that we're going to go through the lower limb a little bit faster than we did the upper limb, and a lot of that has to do with the fact that there are a lot of similarities between the upper and the lower limb. So, similar to what we had in the arm with just one bone, same thing in terms of the thigh. We'll just have the one femur, then you'll have the two bones associated with the leg, like we had in the forearm, and then particularly when we get to the ankle and the foot region, there will be a lot of similarities, not only in terms of numbers, but in terms of just names in general for these bones. Okay, so let's just kind of think overall, though, in terms of the lower limb and what the lower limb does. If you think about standing upright, so not sitting or whatever, you are really putting a lot of weight in terms of the lower limb, so the lower limb needs to be a little bit bigger, a little bit more robust than what we had for the upper limb. Remember, in upper limb we were thinking mobility, and not that we don't have mobility in the lower limb, we most certainly do, but it's not as freely movable as what we had, say, in the shoulder joint in certain regions of the upper limb. Also extremely important in terms of the lower limb is locomotion. You know, that's kind of key. That's kind of a big deal when we're talking about the lower limb. So there are going to be a lot of structures, particularly when we get into the joints, to allow for our most robust and our smoothest forms of locomotion associated with our bipedal stance and locomotion. Also, we need to maintain balance. So the thorax and the axial skeleton will play a big role in that, but particularly when standing or, say, in the middle of locomotion where you have one foot up in the air, you need to be able to maintain balance with the other side, the other lower limb. So there's going to be a lot of muscles that'll really play a role in terms of keeping that balance. And when we talk about the lower limb, we are going to split this into 5 regions, particularly when we talk about the muscles. The gluteal region, you can kind of, you're going to have attachments up here in terms of the pelvic girdle as well, which we've already talked about, but that gluteal region will be associated with those 3 largest gluteal muscles that are on the posterior side. Then we will have the thigh, sometimes referred to as the femoral region, the leg, or the crural region, and then, of course, the foot. And kind of in between here, you'll have the ankle. All right, starting proximally and moving our way distally. Recall, and if you need to review, we did talk about the coxal bones or the hip bones in the pelvic region, but also extremely important in terms of the lower limb as well, because this is where you're getting the articulation with the femur. So recall, the head of the femur, which is always going to be medially facing, will articulate with the acetabulum of the coxal bone or the hip bone. And we have a really good fit here in comparison to what we had with the shoulder joint. So the head of the femur fits pretty well in terms of within the acetabulum. So that's an important difference there between those two ball and socket joints. Just distal to the head, you're going to have this kind of pinched in region of the bone, which is referred to as the neck. So the neck is going to be between the head and the tubercle regions right here. And this is a relatively weak area of the bone, and it's also one of the most commonly fractured areas of the femur. So that neck fracture right here that you can see on this radiograph. Oftentimes when you hear the term a fractured hip, in fact, what they're actually referring to is not a fracture of the coxal bone, but instead a fracture to the neck of the femur. So in essence, kind of a fracture to the hip joint region, but specifically more in terms of the neck. And recall when I was talking about the scaphoid bone of the wrist in terms of it being fractured and how it doesn't have a very robust blood supply. And so if there is a fracture there and that blood supply is disturbed, you could have what's called necrosis or avascular necrosis, or AVN, with the scaphoid. Well, the same type of thing can occur here at the neck of the femur. So if you have a fracture here, the blood supply in this particular region isn't so great, and particularly in terms of heading over to the head as well. So you can have avascular necrosis associated with this proximal portion of the femur. And individuals that are osteoporotic, particularly advanced osteoporosis, this is a fairly common type of fracture that can occur. All right, continuing with our discussion on the more proximal portions of the femur, you're going to have the laterally placed greater trochanter, which you can palpate on yourself. It is a palpable structure. It's always lateral, kind of think opposite to the head of the femur. And as its name would suggest, it's going to be greater or larger than the lesser trochanter. And you're going to have more muscles attaching here. And here are just three. There are more smaller muscles that also attach here as well. But importantly, the gluteus medius and minimus will attach here, as well as that piriformis. You recall my discussion of the key to the hip. So that piriformis will traverse the greater sciatic foramen, or notch, and will insert on the greater trochanter. The lesser trochanter is going to be the smaller counterpart. You can only really see the lesser trochanter from a posterior view. And you are going to have a muscle referred to as the iliopsoas attaching here. And that iliopsoas will actually originate or have its proximal attachments associated with the ilium as well as parts of the vertebral column. So you have a fairly long, it's actually two muscles that combine and have a common tendon on this lesser trochanter. And this muscle is really important in terms of flexion of the hip. So although a smaller tubercle, it's a very important muscle that attaches here and is going to be the most dominant muscle in terms of flexion of the hip. Still on the posterior side, but kind of moving down more towards the body or the shaft of the femur, will be a line referred to as the linea aspera. And dependent on how robust the adductor muscles are, will dictate how large the linea aspera is. So sometimes it's extremely obvious in certain individuals and others not so much. And so again, this is on the posterior surface of the shaft. The adductor muscles are these muscles that you can find on the medial portion of your thigh. And so they're going to attach kind of up associated with the hip girdle region, and then it will distally attach on the linea aspera. So if I kind of go back to that one, individuals that adductors are going to do exactly what they sound like. They're going to adduct the hip. So if you think about an individual that is sitting on a horse or rides a horse, quite often they are going to kind of consistently be adducting their hips to kind of stay in place on the horse. And so oftentimes those individuals that embark on that type of activity will have very robust linea asperas. Okay, now we're moving into the more distal portions of the femur. And you're going to have epicondyles similar to what you had on the humerus. So you'll have medial and lateral epicondyles. Here is the lateral, here is the medial. They're not quite as different as what we had on the humerus, with the medial epicondyle being significantly larger than the lateral. So for me, I always try to find that fibula, which I know is going to be lateral. The tibia will always be medial, and that will help me in terms of understanding which one is which. And you're going to have some very important ligaments of the knee, some collateral ligaments that are going to be attached in this region. And then the medial and lateral condyle. So similar to what I did with finding the tibia and the fibula. So we're looking at a posterior view here. And it's really in this posterior view that you can better see the condyles of the femur. These are nice and smooth, like a lot of articular surfaces will be, because articular cartilage covered this during life. So I know that this one's going to be the medial one. not only because it just says so right here, but because the tibia is right here, whereas the fibula is always lateral, so this would be the lateral epicondyle. So this will be the femoral components of the knee joint. Now, kind of going back to this picture real quick before I move on to that other one, you should see this bone that is sitting kind of right on top of the distal part of the anterior portion of the femur, and that is the patella. We colloquially refer to this as the kneecap. And I love, love, love the patella because you know I love a good sesamoid bone, and this is the largest of the sesamoid bones. It is, and as we recall, sesamoid bones are going to form within tendons, and specifically the patella is forming within the large quadriceps femoris tendon. It even kind of changes its name at some point to be called the patellar ligament, and we'll talk about more specifics there when we get to the knee joint. So it's really increasing the leverage of that quadriceps femoris. It's also helping in terms of the amount of friction that occurs in this region as well. You can see on this particular side, if you look at it closely, that this is nice and smooth on the posterior side because that is what's directly articulating with the femur, whereas it's a bit more robust on this anterior side because it is not, articular cartilage did not sit there during life. Okay, moving into the leg now. So oftentimes colloquially we refer to the whole lower limb as the leg. That is not correct. The leg is going to be this region here. And it will have two bones similar to what we had in the forearm. So you'll have the much larger, more robust, weight-bearing tibia, and then which is on the medial side, and then the fibula, which will be lateral. So let's start with the tibia first, and then we'll talk about the fibula. As I mentioned, this is larger. This actually, I think this is kind of a really great colloquial name. I'm not super into colloquial names, but shin bone is important because if you palpate your shin or your anterior portion of your leg, you can feel your tibia almost the entire way. You can palpate that tibia really fairly clearly because it is going to be almost subcutaneous in many areas. In some areas it'll be covered with muscle, but you can really particularly feel kind of this region of it right here. So oftentimes you'll hear the tibia referred to as the shin bone. You will have medial and lateral epicondyles, which are basically just these barely concave areas at the very top of the tibia, and this is where the femoral condyles will articulate. So the lateral condyle will be on the same side as the fibula, whereas the medial will not be. It'll be on the opposite side. Also, we'll talk about this in a moment, but if I don't have the femur to kind of help out, or a fibula, the medial malleolus will always be medial, as its name would suggest. So that medial condyle will be on the same side as the medial malleolus. If you move just distal to those condyles, there'll be this bump right here referred to as the tibial tuberosity. And this is a true tuberosity. It can be quite large, and that is because this will be the distalmost attachment for that quadriceps femoris tendon. And that muscle is a giant muscle. When we're talking about groups of muscles that are big, this is pretty high up there. So you're going to have a fairly robust projection associated with the tibia. And then lastly, distally, you will have the medial malleolus, and as the name would suggest, and as I already mentioned, this will be medially placed. Right here you will have the talus, which is one of your tarsal bones, and you kind of put these together and you're getting into that ankle joint region. So this is, if you feel the medial portion of your own ankle joint, you are feeling the medial malleolus. The fibula actually is, so this is the other leg bone. This will be the lateral one. It does not actually articulate with the femur. There will be some ligaments that extend from the femur to the fibula, but it does not directly articulate with the femur. It does articulate with the tibia in 3 separate places, similar to what we had in the forearm. Now, tibia is where all that weight is going. That is the weight-bearing bone. Fibula is not, but a lot of muscles attach here. So it's really serving primarily as a muscle attachment site. And there's really two main structures I want you to know here, and they're kind of hard to tell apart. So if you're just holding a fibula, it's kind of hard to tell the difference between the head of the fibula and the lateral malleolus, because they're on the ends of the bones, and if you're just holding one without having any context, it can be difficult. The head of the fibula tends to be a bit more robust, kind of more square-like, whereas the lateral malleolus tends to taper. And I like this image of the anterior view here. So the lateral malleolus, if you feel the lateral side of your ankle joint, you're feeling your lateral malleolus. And you can see that it extends a little bit more distally than the medial malleolus. And you can kind of feel that on yourself. You can have a fracture to these medial ends, or excuse me, the distal ends of these leg bones. Typically, and this is referred to as a Pott's fracture. It could be one or two, or one or both parts of the fibula and the tibia. Typically, I don't really love where this is located. I would put this a little bit closer to the medial malleolus. And this is, if only one is going to be fractured, it's typically the lateral malleolus or kind of the distal end of the fibula. But you can have both of the both leg bones having a fracture in a Pott's fracture as well. And that happens a lot with those kind of sudden movements that can occur associated with the ankle joint, because a lot of those tendons, or excuse me, those ligaments are going to be kind of close up in this region as well. Lastly, we're getting into the foot region. Similar to how we had carpal bones, we're going to have a lot of tarsal bones, but we will have one less tarsal bone. So there will be 7 tarsal bones, whereas there were 8 carpal bones, but the tarsal bones are quite a bit larger than the carpal bones. And particularly these first two that we're going to discuss. So the talus right here, which is kind of the superior most of the tarsal bones. This is the one that articulates directly with the tibia and the fibula. It will play a role in terms of the talocrural joint. That's where the talocrural is the real name for the ankle joint. And so crural means leg, so it's articulating with those 2 leg bones. And then the talo is from the talus. The heel bone and your largest tarsal bone is the calcaneus, and it will be located inferior to the talus. And this is the largest. You can palpate your calcaneus as well if you're feeling the very bottom of your foot around the heel region. And then you have the rest and all the rest. Not that they're not important, but they're just not quite as large. They're not forming as important joints in these regions. You're going to have the navicular, which is this is going to be medial. This will be lateral, so the navicular will be more medial. The cuboid here, and then the 3 cuneiforms. And so these are either named 1st through 3rd cuneiforms or medial, intermediate, and lateral, as you can see here, with the first being the most medial. And then the bones of the forefoot. These are going to be the metatarsals, of which you have 5, similar to the metacarpals, but recall that your first metacarpal was on the lateral side, so the one associated with the thumb is your first digit, and in your anatomical position, that would be lateral. The first digit when we're talking about the foot is going to be medial, because that great toe or your big toe is going to be medially placed. So we number those from medial to lateral 1 through 5, as you can see here. 1 is by far kind of the largest or thickest, and they get kind of progressively smaller, even though this 5th metatarsal will have this process right here that is a little bit more robust. And then you will have a very similar organization in terms of the phalanges as what you had in the hand. You will have 5 proximal phalanges and only 4 middle or intermediate. So same thing here in that first digit, you do not have a middle or intermediate. And then again, you would have 5 distal phalanges. And the distal phalanges on the foot are extremely small. Sometimes they don't even have that really distinct kind of shape that you see in a lot of the the phalanges. Sometimes it's not quite as easy to identify in that way. They almost look like small sesamoid bones. Okay, so those are the bones of the lower limb. I hope that you saw a lot of those similarities to what we described in the upper limb, and can kind of take that information and combine it into just an overall understanding of the appendicular skeleton. All right, here's a quick question. I think you're going to get it and then kind of write off, and if not, you'll know that's an area you need to focus on. So when someone says they have fractured their heel bone, you quickly recall they are speaking about which tarsal bone. Is it the calcaneus? Is it the cuboid? Is it that second cuneiform, the talus or the talus, you'll hear it either way, or the navicular? And so really, what is that heel bone? Which bone is that? And I hope you understand it's that largest tarsal bone, your calcaneus, right here, is often colloquially referred to as the heel bone. All right, great work here. We are going to move into the joints of the lower limb, and I can't wait to get into that. Nothing is more fun than talking about the hip and the knee joint and the ankle joint, all so much fun. Thanks for your time and attention, and please have a great rest of your day.